So an important day today because we're bringing what we've done before and adding on to a subject called deep tissue. So what's your association with deep tissue? Sorry? Compression? Yeah, so kneading, petrissage.
Getting into the muscle,
Getting into the muscles. Work it.
Yes, deep.
Deep.
And it's more specific
Yeah, more
area that
specific.
you're treating rather than general.
Right. Is pain is part of it?
Yeah. Should it?
Could be. So we have to be careful. Yeah. What do you think your client association, like keywords, when you tell them deep tissue, what would they say?
Pain.
Pain,
be healed.
Relief.
be healed, relief,
Aches.
aches,
Efficiency.
efficiency. So something therapeutic. Right. So it can be words that associate positively or negatively with deep tissue. I think big negative part is pain, that is causing pain. But does it really have to? Not necessarily.
But then you have
So-
a no pain, no gain, which is also positive.
There is
Good
that,
pain.
but
Good pain.
and up to a point, you can have an ache coming from the treatment. But I would say that having a lot more pain, maybe not done the treatment correctly. You might not warm up the tissue well, or you do too much, or you do too quickly.
It has to do also with the perception of the client of pain. Some people
Oh,
like
yeah.
it, some people less.
Yeah. So some people
People
are
ask for more.
Yes, they don't feel it. Yeah.
No, or they feel it in a positive way.
Yeah. There are that perception of what is it painful or not? Some people would be quite apprehensive about it and they would feel pain right away without even feeling the pain. Okay, so what sort of technique we've learned so far to do the deep tissue? So we lead petrissage, friction, compression. Have we learned the forearm technique?
Yeah.
Yes.
And
Yeah.
how
So we did everything. Yeah? So actually it's going to be about
The
a bit
elbows
more.
we didn't do, did we?
Yeah,
We didn't
yeah,
do
we
elbow.
did the elbows.
We
Well,
did
we
little
did a
bit.
bit.
Very
of
little
elbows.
stuff.
Yeah, because we
Oh,
went
yeah.
down.
So a lot of it probably is going to be a revision on what we've done. So we've done a revision on that, and then after that, I'll let you work, and then we'll do also joint mobilization today on the shoulder, mostly shoulder and neck. These are the two main areas.
We're not head
Okay.
today.
Sorry,
We're not doing head today.
if we'll have time. Okay, so after a hold, taking the towel, mat. I'll do it on the spine just because it's the easiest one. By the way, can effleurage be deep tissue?
Can, yeah.
Yeah. You can do it quite
But not
deep.
on the legs, for example. If you do that deep tissue straight, can you?
You can do effleurage as a deep tissue. I'm trying to avoid the music.
Yeah, with a different rhythm.
Right, so petrissage. What is the relationship to depth and speed? The deeper you go, slower. Okay. Good. Then after that, I can do on the other side, and then I can do. What do I do now? Compression. What is the difference between petrissage and compression?
Focusing on one
Local,
point.
Surface area, static, the other one is moving.
more static. What-
Surface area. Surface area.
Surface area, you're staying on the same place, yeah,
As opposed to moving.
as opposed to moving
That would be deeper.
deeper. Okay, good.
More focus.
So when I do compression, can you come closer? Do you see what happened to the blood circulation? I do compression and then leave it. You can't see much? Did you see it becomes more pale and then it comes back? That's the pumping effect of the compression. You're reducing the blood circulation in that area and then increase it. Reducing and increase it in a way, it's almost like taking a connective tissue and just pressing on it, squeezing it, allowing more fluid to get in. Stressing, compressing out. It's almost like a kickstart for a stuck car. Yeah? When you need a car to move, then you put it on the first gear, put on a clutch, and then get it to run, and then it runs by itself. Yeah? So that's a compression, right? So compression, let's think about how many types of compression you can have. So you can have thumbs. Anything else with the thumbs you can do?
One over the top of that.
How do we call that?
Reinforced.
Reinforced. Good. What else?
Pressing with the palm of the hand.
Yeah, like that. That's quite good.
Did you use something with your knuckle?
So you can do that. So still with the thumb. So there are few possibilities with the thumbs. And is any of these is better than the other? So why do we do so many? To give your hands a break. So if that would be too much or that would be too much, then you can relax the other thumb. So the best technique, the technique that fits to your hands and give and actually have the good effect. Good. What else in terms of Petrissage compression? We can do finger peg compression. Good. You can do the same reinforced. Yeah. And then knuckles. Yeah. You can do one knuckle. So actually I put the thumbs as a support.
I still find it difficult to get the right spots.
It is.
Did you kind of drop off it?
You
Yes.
get onto a bone and you think you're there, and then, and then you
Yeah.
point
So in a way, the balance, the balance is quite important. So in any position, first you palpate, and then you're finding the place, and then slowly you move in.
Can you like show us on her like a spot and we can feel it to see if
Yeah,
we're feeling the right type
that's
of...
my problem, finding areas to do compression.
Because I feel like a whole area needs it as
Yeah.
opposed to one little
So
area.
you do more maybe petrissage.
So do you have a spot there that she hits it?
Let's do all of it, and then after that we'll have a look, and maybe I'll come around you
Yeah, because that
and
would
do
be
that.
quite
Yeah.
useful just
Okay.
to be able to know that you're
Sure.
feeling the right thing.
Actually, the spot itself is quite subjective.
That's it. If you ask them to tell me exactly
It's
where.
quite subjective. You think that, oh, they will tell you the point. Did we discuss that yesterday about helping pathologies? Or the same thing here. The point is where I feel and they feel, the client feel, where it is. It's subjective. It's a tender point. It shouldn't be like, oh yes, I see a 0.5 millimeter point here, and I press it, and it's gone. Yay. No. It's a lot more tailored around their subjective feeling. You know? I can show you few places that I know would cause pain. How is that? Yeah? Okay. There are some tender points I know that can be tender to all of them, almost all people.
Yeah.
But it's quite subjective.
Yeah.
I don't want to be the doctor, they are the doctor. So they tell us where the tension is and where the tenderness is. Yeah? That's why I try to avoid it. Because it's really subjective. But
You
it's
try to
important to
avoid
know it.
compression.
Sorry?
You try to avoid compression.
Avoid asking.
No, avoid telling you where it is because it's quite subjective.
Okay.
Yeah? Okay. Knuckles, yeah, you can do with that knuckles, you can do a whole knuckles. I don't tend to move my fingers much, I try to move the whole area. Yeah?
Is that not a good thing to do that with?
I don't think it's great. Depends, feel it. If you feel stress in your hand, don't do it. Okay? Okay? Where else? I think we've covered pretty much all of it, yes? Now, where to do it? We did the how to do it, how to use our body. Now, where to do that? I'm going to now work on the back. So, actually, let's do it at I'll treat, and you tell me where do you think I'm doing the compression. On which muscle am I? Which one?
Medius.
Medius or gluteus maximus? Yes. Gluteus medius would be more to the side.
Maximus is your bottom, isn't it?
Yes. Yes. So this is the upper gluteus maximus. Yeah. Good. Yeah. Talking about back pain, yeah, it's very common to have tenderness around here. People don't aware of it, and a lot of it is to blame the sitting. So if from the case history you know someone who've done a lot of sitting, then try to palpate around. Again, some people, I feel tightness, and some people would say, oh, it's very tender, but I feel it actually underused. So for both situation, I can do that. But if it's too tight, compression would be good. If it's too underused, maybe a bit more stimulation technique, I think. Yeah, more maybe light and quick petrissage, to get more stimulation around that.
In terms of you feeling, how do you feel the difference between underused and overused?
Overuse would be tight, big, tense. Underuse would be weak. The muscle might be smaller. Where you're supposed to feel, ooh, a muscle, suddenly it's like there is not much there. It's the muscle is it's called atrophy in a way. Atrophy means just getting to be smaller. Okay, good. Which muscle am I now on? Oh, sorry. It would be quadratus lumbarum, yeah, or external oblique would be a lot higher. Good. I can reach it also from the other side. So it's not the superficial erectospiny. Good. Now I'm on erectospiny. Good. So relax, and then you can do a bit of effleurage around, petrissage, and again re-engage in compression.
Do you always do the breathing or not?
No, mostly when it's coming upward.
Do you know what? I had somebody the other day, and she's very quite overweight, very overweight. Actually, she's about 18, 19 stone. That thing, very stressed, very tense. And I just couldn't. I needed to take a drill. It's just solid,
Yes.
solid, swollen.
Yep.
And so hard, so tiny. I nearly, she nearly. You just should have come back.
And no neck.
And no
Yeah,
neck.
no neck, and you can't
A
find the
number of clients
spine.
with no
Okay.
neck.
Yes.
And,
Yeah.
and you would have needed it to say come back every day until you even
Okay.
started to make a dent in it.
Which muscle am I now on?
Deltoid.
Nope.
Trapezius.
No.
Infraspinatus.
Infraspinatus, because it's on the shoulder itself. Deltoid will be here. Upper trapezius would be here. Yeah, rhomboids would be here. So you have to. Do you see the medial border of the scapula?
Yeah.
Yeah. This is the scapula. Yeah.
Yeah.
Okay. So try to get the palpation and sort of estimation where things are. Yeah. Good. Let's do trigger point on teres muscle.
Teres major.
Relax. Okay. So, shall we move on into forearm? Yeah? Okay. Now, in the forearm, the most important things is to feel like you've had 2 pints of beer and you're quite relaxed, almost like reclining onto the client. Your weight should be, you can do it either with this side or that side, whatever comfortable for you. Your body weight should be a little bit behind the forearm. And at the beginning, you just relax. Once you feel the tissues allowed you to go, it's actually not only the tissue, the client would allow you. You know, when you go deep, the first inclination of the client is to say, okay, you know, stop it. We don't want it. We want to, I call it, sneak under the barking dogs. So her muscles would say, oh, you know, tight, 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 let's tighten it, dangerous. Muscles not used only for movement, they're actually the bodyguards for the body. If something happened and we're scared, we use muscles to protect. So you need to be aware of that and be quite calming about it. So it may take longer time to sink in. Can't sink in quickly.
And tiny bit of arm angle makes such a difference.
Yep,
Because
yep.
if you
So if you do the bone or not the bone,
you stick the ulnar in, it really hurts.
I've had a lot of positive.
and then once you start moving, be aware that you need, after a little while, to do the correction with your legs, yeah, and come a bit closer. So that movement. Why? Because once you're moving, you end up having the elbow, the forearm, very forward, and it will glide too much. Your weight should be just above that. So you go, and then you change it. You go, and then you change. It might need a few times. Okay? Let's take the shoulder. Yeah? Let's take the shoulder and see how you can do deep forearm technique onto. Have I shown you a few? Yeah? Have we done this one?
Yeah.
You can do actually, it's almost like, remember that position?
Yeah, it's good.
So you do it with the forearms. And again, I feel really heavy. And the key is really the knees. You're bending your knees and the weight goes down one side and the other side. You can do it with the upper trapezius, but it's quite harder. This surface, straight up, is a lot easier. This surface comes towards you. You need to bend a lot more. And what I do really is push it this way and push it. So I have the resistance and then I push it and then let go. And then push it and let go. Don't try to do it to the side because you have the bony bit here. Quite not nice. I mean, some people it may be, but not very nice. So,
I think it's great.
yeah. Good. If you cannot do that, do one at a time.
That looks more comfortable.
Yeah, a lot more comfortable.
Not so over the client, I think.
It's not that much over the client, yes.
Because it's a bit irritating, I guess.
You can do that. A combination of it would be to take the hand, put it on the back, hold one hand over here.
Yes, some people just don't have that.
No. Like working.
Okay, good.
Cool. Is it possible to keep showing some massage techniques when you lift and try to get under the shoulder blade?
One at a time, okay? We'll do that maybe with mobilization, when we do the shoulder mobilization. Anything else around here?
Joel, you showed me a nice forearm one last week. You know when you go up the back and you go over.
Oh yes, 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 yes. So you do that movement. When you come to the scapula, do you see what happened? I can encounter the scapula. So what you do, you're turning. So this is a bit of a pose. You continue, maybe not as deep as, and then you're rolling down. Yeah? And then you can continue with that movement. So try to do it as long as you can, really. So it's quite a long swifting movement. Yes. I need to do correction, turning it. Now there is enough space between the scapula and the spine. Yeah? Still there, getting the hands underneath and then really stretching the shoulder down. Okay? Another, something that I really like is that one.
Wow.
It's really good. It's a bit difficult. Look, this hand is less of a problem. And what you can do, get a little bit of the upper gluteus muscle. This hand is problematic because of the scapula. You have to renegotiate every time you do it.
I found that one's good on bigger people because you cover like a bigger
Yeah.
cervix area.
Of course. And you can do even that. So how do we say? Start with an effleurage, finish with the forearm, yeah? With a deep tissue.
So that could be really classed as deep tissue then, can
Is it deep? Yeah. It's quite deep, yes.
You make it look so effortless, that's why it doesn't look so deep.
So I probably lean a lot, yes? If the camera would look, I'm actually leaning all my body. If you're staying there, no risk, no gain. But if you're leaning, yeah? So look at the weight, come from the side and see. I'm actually straight, and then come and lean forward, and then back. So there is that point, you see that point? My body is actually on top. If you're missing that, you can do the same movement, not much happen because you're not taking that risk of doing that and then falling forward. There is no falling forward feeling, there is no force. It's not in there, okay? Good, you can do the same thing here. It's the same as we did here, but now you do it to the side. Yeah? Should we give it a go? Yeah? Fantastic, good.